Okay, let's start. Go ahead and get started. Good afternoon, everyone. Thank you so much for joining us. Today, we have an incredible lineup of experts in their fields to discuss specifically their role in responding to and preventing firearm injuries, how this work fits into a public health approach to firearm injury prevention, and also how they, as professionals, process the vicarious trauma that comes with doing this very difficult work. I'm sure many of you can relate to some of that, and maybe that's why you're tuning in today. But whatever your reason, we're very glad to have you. My name is Josh Fleetman, and I'm the campaign director for Ceasefire PA, the Commonwealth's gun violence prevention organization. Our mission is to organize with communities closest to the issue of gun violence, hold those in power accountable, and maximize the strengths of every member in our broad coalition. And one of the big reasons we're convening this panel of experts for you today, in addition to May being National Trauma Awareness Month, is because we're making an intentional effort to build a broader and stronger public health coalition of doctors, nurses, first responders, and other healthcare professionals to get involved in gun violence prevention. Because you deal with the impacts of the firearm injury crisis every day in your work. Maybe even you yourself have been threatened or directly impacted by firearm violence. We seek to empower you with a more systematic understanding of firearm violence rooted in data and the lived experiences of your colleagues here. And if you'd like to join our work, we hope to help uplift your voices in our efforts to advocate for policy change in Harrisburg and Washington, D.C., because you have a level of credibility that other grassroots advocates do not in the eyes of policymakers. That's why we've specifically hired a new public health partnership coordinator, April Smith, MPH. Maybe you got your invite today from April. I want to especially thank and acknowledge April, who will be a great point of contact to continue building more partnerships with all of you. And she'll also, critically, be able to help you claim your continuing education credits, which she'll be following up with you via email later next week. Before we dive in momentarily, I just want to thank our co-sponsoring partner organizations, the Society of Trauma Nurses, the Pennsylvania Trauma Systems Foundation, the American Trauma Society Pennsylvania chapter, the Physicians for Social Responsibility Pennsylvania chapter, and the many other leaders and organizations who help make this possible, too many to name here. And of course, I want to thank our panelists, each of whom you'll hear from for the next 30 to 40 minutes or so, and then we'll have lots of time at the end for your questions, which you should please feel free to submit using the Q&A box at the bottom of your screen. So thank you and welcome to Dr. Darcy Motion-Ross, the Medical Director of UPMC Presbyterian Hospital's Consultation Liaison Psychiatry Service. Sunny Jackson, MSN, she's the Injury Prevention Coordinator at Penn Medicine. Jill Volgraff, MSN, she's the Director of Trauma Operations at Temple University Hospital. And Dr. Bob Baracco, a trauma surgeon at Lehigh Valley Health Network. What we would like to do next is hear from each of our panelists about their work and their approach to this, their approach almost from the order in which each of their specialties are engaged in the cycle of a firearm injury, from the initial intake of the patient to surgery to psychiatric support afterwards, and then all the way around to the prevention of the injury and the violence in the first place. And afterwards, again, we'll have plenty of time for questions, so please put your inquiries in the Q&A box as they come up, and we'll do our best to get to as many questions as possible with a hard stop at 1 o'clock to let you all get back to your busy schedules. Okay, let's go ahead and dive on in. First, Jill, you're the Director of Trauma Operations at Temple University Hospital in Philadelphia, one of the busiest trauma centers in the state, if not the country, with huge numbers of gunshot wound victims. Can you walk us through what you and your team do when a gunshot wound patient comes into the trauma bay? Tell us more about how your work is shaped by firearm injury, please.
Sure. Thanks. So Philadelphia has the unique experience of being a scoop and run city, which means patients that are injured with penetrating trauma can be picked up by the police and brought directly to a trauma facility, kind of bypassing normal EMS. So we often get these patients with little or no pre-notification. So it's really, I think all healthcare is a team sport. Trauma, specifically at Temple, that's my experience, is the ultimate team sport. So, you know, we have to count on our EM colleagues to start running the trauma, the nurses, the physicians, prior to even our trauma team getting there, because they've arrived and we are just finding out. And you know, so it takes the team, it takes the right people in the right position, doing the right jobs at the right time. And that's really it. Communication is key. You know, we're very fast paced. We need to be making those critical decisions quickly, to get the patient to the next phase of care. Is that CAT scan? Is that OR? And we need to be in the right place at the right time. You know, we rely on our victim advocates now that are including and communicating with the patient, with police, with the families, to help kind of get everyone on the same track and have the same knowledge and communicate as needed. So you know, real proud of the work that people that are seeing these types of injuries do every day. So thanks for having this. It's fantastic.
Thank you so much, Jill. Now let's bring in Dr. Bob Baracco. He's a trauma surgeon who regularly sews up bullet wounds. Same question, Dr. Baracco. Bring us into the operating room with you when you're facing a patient bleeding out. You know, what are the first, second, and third things you do? What happens afterwards? Tell us about your work responding to firearm injuries, including your involvement with the American Trauma Society.
Mute. There we go.
There you go.
The first thing that happens is we'll get a page across our paging system about what level trauma. There's different levels of responses. So gunshot wounds, especially proximal in the torso, in the head, etc., are usually the highest level alerts. And so we'll get a page. We don't often know what is coming, just what type of alert and when it's arriving. So we all gather, as was mentioned earlier, it's a team sport. We all gather, nurses and assistants and X-ray and respiratory and residents and students and physicians, attending physicians. And we'll gather and do a little pre-brief, find out what we know so far, what did EMS tell us, and we'll await the patient. When the patient arrives, we'll take a quick report from EMS of everything that they have done so far and what the condition of the patient is at that point. Then we start the ABCs of trauma. And ABCs, you know, trauma surgeons try to keep things simple. So we use an alphabet mnemonic, and ABCs stand for our priorities when a patient comes in: airway, breathing, circulation, disability, and exposure. And so what we do for that is airway is, do they have a way to get oxygen in and out of in their lungs and carbon dioxide out? So we make sure that airway is open. If it's not, we'll have to put one in. We'll have to put a breathing tube in to help them. Are they breathing spontaneously? Might be another reason we have to put a breathing tube in and help them with their breathing. And then C is for circulation, and that has particular emphasis in gunshot wounds because you're looking at their blood pressure, their pulse rate, and are they actively bleeding anywhere? Or signs that they could be actively bleeding somewhere that maybe you're not seeing. And then D, disability, is neurologic exam. So particularly important for gunshot wounds to the head or the spine or major nerves. Do they have any neurologic deficits? And then exposure, we look at the whole patient from stem to stern. And so again, just finding what holes there might be and piecing them together. You know, we can't necessarily tell where a bullet came in or exited. There may not be an exit wound. And so we really don't know where that is. So depending on the condition of the patient, it could be, if there's no exit wounds, it could be, and they're stable and they're relatively stable, it could be some x-rays to find out just where the bullet is and what damage might have been done. We also can do an ultrasound to see if there's blood around the heart or in the abdomen. And then if the patient is injured, of enough severity, we'll end up taking them, as you mentioned earlier, to the OR for what we call a code omega at our place. It's amazing the devastation of firearm injuries. You know, trying to understand the damage is really hard unless you've actually seen it. You know, everyone sees these nice little cute bullet wounds usually in the TV shows that occur, and oh, that's it. And then in most of the TV shows, oh, I'm going to hold pressure. Doesn't really work because you can't really put pressure on what exactly is bleeding. Sometimes in extremities you can, but in the abdomen and the chest, oftentimes, you know, that's often not sufficient, and you really need to be in an OR and treating that patient. And so again, we'll do that, and depending on the wounds, you can see fatal wounds to the head, you can see wounds to the chest, and in an unstable or really sick moribund patient, that means opening their chest to fix the damage, maybe operating on the lungs, the heart, whatever needs to be operated on. Abdominal gunshot wounds can injure so many organs and major vessels that these are challenges for any trauma surgeon. And then there's the devastation to the loved ones. You know, sudden, violent, disabling injury or death. You know, no one's really prepared for this. And then having to tell them about what happened and watching their response can just be absolutely heart-wrenching. And you know, from that point, you know, we'll have to see what happens, you know, if the patient made it, if the patient didn't. And we'll have to give them whatever news that is.
Thank you, Doctor.
Did you want me to go into the what the ATS is doing? I think you mentioned it also. So as a
Yeah,
follow-up.
please.
So yeah, so with the American Trauma Society Pennsylvania chapter, of which I'm the president, we're working with a work group to look into the literature regarding firearm injuries, and especially see if there's any literature as it pertains to the Commonwealth of Pennsylvania, and what measures that we might recommend for firearm safety and you know, curbing this firearm violence pandemic. So we have embarked on that. It's a slow process. We're gaining involvement of organizations and folks continually, and really looking to result in some recommendations that would fit the Commonwealth. And I think one thing, you know, I know people are often afraid of is, you know, especially if you try to screen for firearms, which we'd love to be able to do. And some places do, some places don't, because folks get really skittish. Oh, they're asking me when I come to the hospital for any reason, just like they ask you, do you smoke, do you drink, do you have firearms in the home, you know, are they safe? That, oh, I don't want, because they might take them away. That's not the idea. The idea is to try and identify where there might be risks and to help them mitigate them, and give them advice and recommendations for that. You know, we're not in the business of taking them away, right? That's not what physicians do, but we are in the business of trying to make sure people are as safe as they can be, and have at least the appropriate knowledge to be able to make those decisions.
Well said. Thank you. And just a reminder to everyone watching, please feel free to drop your questions in the Q&A box at the bottom of your screen. As your thoughts come up, as you hear these great panelists speak, please feel free to either direct questions to a particular panelist or just the group as a whole. Now let's please bring in Dr. Darcy Motionross, psychiatrist at UPMC Presbyterian Hospital, a level 1 trauma center in Pittsburgh, because obviously the impacts on someone's health after being shot transcend just the physical. There's deep psychological and emotional trauma there. Dr. Motionross, a similar question. What are the factors that you consider as you're preparing to see firearm injured patients? Tell us about your general approach and how these evaluations typically go. How do you juggle their mental health needs with their acute medical needs? And what are some of the resources that you're able to provide the patients for the long term?
Thanks so much. Yeah, so I think, you know, so I'm a psychiatrist that works just in a medical hospital. So, you know, sometimes we're sort of putting out fires when we evaluate. We're seeing what their acute psychiatric needs are. Sometimes people that have been shot, you know, have been on a lot of meds, have had surgery. Perhaps they're a little agitated after surgery for whatever reason, or, you know, from other sequelae from their injuries and trauma. So we want to make sure that we're treating any acute psychiatric needs first. We also, as we're kind of doing that, as we're kind of supporting this patient, building rapport, we want to determine as we evaluate, are there any other chronic psychiatric needs, mental health needs that we need to be taken care of? Are they on the right meds? Were they in treatment before? Have they kind of dropped out of treatment? Is there something else we need to be treating? Is there an active substance use disorder? Are they withdrawing? So again, we're taking care of the patient where they're at in that environment, and then we've added a new acute stressor on top. So when we think about after a gunshot, it's a very overwhelming, very traumatic thing, and so we're really just trying to make sure we're kind of doing the first aids of mental health care, making sure everybody has their needs met, seeing what those needs are, and kind of thinking about, as we build that rapport, normalizing mental health care, educating about things that could happen, sort of how the body reacts to trauma, and how you might be processing that. A lot of people in the hospital have a lot of flashbacks of the event itself. They sort of, they can have nightmares that wake them up from sleep. In the beginning, a lot of times that will taper off, and it's a really important time to be normalizing that this stuff does happen, and that it's sort of like your brain is processing this huge event that happened to you. So making sure that people really understand in this acute stress time, how we might deal with this, how we might help them get through it, but also educating them, if this continues, what we might be able to do for them. We also just, right, we're a friendly face that can kind of explain some things, and as we build rapport, because we follow a patient throughout their medical hospitalization, right? So sometimes it becomes right there in the ICU, they have one team, they go to the floor, it's a different team. So we're sort of those people that are around all the time. So that can go a long way. And as we're kind of getting there and getting collateral, talking to families, seeing what's up, we also try to coordinate what resources are going to be helpful for that patient moving forward. And they may not want anything now, and that's totally fine. We just want to see where they're at and give them stuff if they decide later on, hey, maybe I do need something. Sometimes we have a really fast turnaround, so we kind of just plant some seeds, and then we allow them to kind of take that in, absorb that, and then move forward. So that's kind of how I approach my evaluations.
Wonderful. Thank you so much, Doctor. So, of course, all this work that we've heard about so far to respond to firearm injury is critical and sadly needed in our society, where about 4,600 Pennsylvanians are injured or killed by firearms every single year. There's an old saying, though, that an ounce of prevention is worth a pound of cure. And that really is the root of what it means to use a public health approach to gun violence prevention. And there's also another saying that hurt people hurt people. The idea here being that if you're a victim of firearm violence, you're much more likely to then also become a perpetrator in a vicious cycle of retaliations that fuel so much of the community-based violence that we see. So let's bring our final panelist, who does the proactive work to prevent future firearm injury. Sunny Jackson is the Injury Prevention Coordinator at Penn Medicine Trauma Center. Sunny, tell us about some of the tactics that you use both bedside in the hospital when patients are recovering from gunshot wounds, and also the work that you do outside the hospital in the communities where these survivors go back to and are at continual risk of being involved in firearm violence.
Sure. So when we think of gun violence prevention, we think of like the two major things we need to address: access to firearms, and then the underlying risk factors that contribute to why we have gun violence. Just a couple weeks ago, I was at the Brady Ceasefire Conference, and someone said it is easier for our kids to get their guns than it is to get the resources to prevent them from getting guns. And that really stuck with me. It's just so true. So we need to really flip that. So the first thing when I think access to firearms, safe storage methods are really important to protecting kids from getting their hands. Like Dr. Bracco said, some of us are like maybe a little scared in healthcare to address, is there a firearm in the home? But we're screening for smoking, we're screening for alcohol, we're screening for diabetes and for cancer. domestic violence, all these other things that may be sensitive subjects and maybe people don't want to talk about, but by doing it repetitively, we got really good at having these conversations. And so we need to give our providers maybe a little more background, a little more education themselves if they're not comfortable with the conversation, to get them comfortable with the conversation. It can be as simple as, you know, is there a firearm in your home? Is there ability to access the firearm in your home for, you know, all the people, especially the little people? And counseling on safe storage options. We're getting ready to launch, actually both here and Temple in Philly. We're going to be launching a really big safe storage program involving gun safes, where we're meeting our individuals where they're at. A lot of people have given us some feedback that the cable locks isn't right for them. So, okay, so what is right for you? A firearm safe where you can put it in makes a lot more sense. There's a code to it, so you can't lose the key. And it keeps the firearms out of the hands of people who don't want to have the access, which is, you know, our young people, our teenagers, anyone like that. It's going to stop their access. Our primary care teams are really, really interested in getting involved with this because they feel like, you know, a little bit helpless. What is their piece of the puzzle? Like, this is definitely their piece of the puzzle. So we're going to be working on really collaborating with them to have the gun safes right there in the clinic for them to hand to their patients right there in the moment. And what does documentation look like? I think that's going to be different probably for every institution, but I think it should be really basic, like screened for presence of firearm. Don't have to say yes or no, just say you screened for it, and then education provided and accepted. You know, doesn't have to get too in detail. Probably the best way to manage that. And so that's one of the really the best things we can do. The other thing is really tightening the laws around the ghost guns. That's our youth are getting their hands on, you know, weapons, you know, in their homes, and then it's really too easy to assemble these ghost guns and move with it. So in March, the House had passed legislation on the ghost guns, and so now we really need to come together and push to get that through the Senate. Really two important ways to limit the access to firearms for our young people, among many, many other things, but I think those are the two big ones that stick to me. And then really addressing the underlying risk factors. And that sounds really hard, but there's some really kind of low-hanging fruit things we can do here as health systems too that are really impactful. Anything, we're already addressing social determinants of health in our people, right? And adverse childhood effects or events. The ACEs and social determinants of health, anything we do to help prevent them or help improve them for our communities is protective against gun violence. These are the resources our people need to, you know, help keep them out of harm's way. Why does it really matter? We had a study done here in Philly. I mean, it's about 10 years old now, but victims of violent traumas, all of them reported at least having experienced one ACE. 80-some% experienced 2 or more, and 50% experienced 4 or more. So I was talking about, you know, the standard ACEs we all think about, abuse, neglect, household challenges that include substance abuse, mental illness, divorce, witnessing violence. But the CDC came out with like an expanded list of ACEs, and they're really important to look at too. Experiencing discrimination, bullying and peer violence, housing insecurity, food insecurity, tying back into our social determinants of health, and then witnessing violence in our community. I can speak for Philadelphia, and I'll speak for Jill. If you ask any individual in our community, like, have you been affected by gun violence? It's unfortunately, you know, it's 100%. It's across the board. They've all experienced it, and it's affecting them now. So if we can address those things, that can be really preventative. And I think the two easiest things we can do as health system is one, like engaging our youth, showing them that first we're here, we care, but second, like that you have options, and this is what could come after school for you. This is a goal for you to work towards. So we hold a lot of, host a lot of high school students and bring them in to meet our staff, and we talk them through, how did you get to your position? So I've been a nurse for 18 years working in trauma, but I came here by a 2-year degree that was pretty easy to attain when you think of what a challenge college is. And then I had my health system pay for my bachelor's degree. I had my next health system pay for my master's degree. and I've worked my way on up. So it doesn't have to be, you graduate from high school, you're fortunate enough to get to college and go from there, that so many people don't take that path. There's so many great stories here in my hospital and probably in your own too, of people who have come in at a very entry level, came in as a patient transporter, and now are running departments. So seeking out those people and having them engage the youth, I think is really, really important. Also something that's, you have the people, you have the staff, and you have the space. So it's not a huge financial investment. It's really something you can come and do, get them exposed to as many things as they can in healthcare. Like, I didn't know what a respiratory therapist was until I worked in a hospital. Didn't know it was ever an option when I was in school. So letting them know all those different things that are out there and available to them, and emphasizing the computer jobs, the IT jobs that come along with the hospital. Like, if we can't keep our network secure, we're going to crumble. So it's not just about medical and touching people. That's like a really big thing that my high school students always seem so surprised about. Like, oh, the computer jobs, they're here too. Like, let them know how to get there. The other thing I think that's really, really important, we did a lot of work between Penn's Injury Science Center and Urban Health Lab on cleaning up and greening neighborhoods. And there's some articles out there proving that this is actually protective against gun violence, and it really helps. They went in and cleaned blighted properties, and they saw a 29% reduction in gun violence in that community. That's huge. And then they saw other really, really great effects too, including improving mental health, decreasing a nervous, anxious feeling. All those things that we don't want to feel all seem to improve when the neighborhood seems to take a little turn. I can tell you from experience, like, we've gone out and done a lot of community greening and helping in our neighborhoods. And we come out with a plan to, let's make this park nicer for our kids. Let's clean it up. And, we grab a group of people and get together, a couple hours on one weekend and get it done. And when we're out there, sometimes the neighbors will come out and thank us, which is fabulous. But moreover, I'll see lots of neighbors come out and look around and, like, things are cleaning up, and start sweeping off their own step and tidying up their own places. So it's not just the property that we addressed, but it's the surrounding ones. Really, everyone's like, oh, someone cares, I'm gonna start caring here too. It really makes a difference. So I think those are like the two low-hanging fruit primary prevention things that we can do as health systems. Secondary prevention, of course, mitigating the damage after the injuries happened. Most of us as trauma centers, we all have decent Stop the Bleed programs. And I think it's so important. For anyone who hasn't heard of Stop the Bleed, it's a national initiative. It's really easy to become a trainer, and we go out and we teach this in the community. It takes about an hour, and they learn those life-saving methods, putting pressure on a wound, packing into a wound, and using a tourniquet to help save a life after someone's had the injury. It's a skill, in my opinion, that everyone should have. Everyone should know CPR. Everyone should learn Stop the Bleed. And I can tell you, Pennsylvania is the last state to require CPR for high school graduation. I'd really like to see us come together and not be the last state to require Stop the Bleed. California is already doing it. Others are joining in. We can't be number 50 again. So getting us together as healthcare providers and really putting some pressure on getting this required as a skill that people leave high school with, I think, is so important. And then finally, the tertiary prevention. What do we do after someone's injured? And I'll tell you, when we're talking about ways to handle the vicarious trauma, this was really how I handled my vicarious trauma. So many years in trauma nursing, and just feeling the hurt was coming to the injury prevention side and trying to be able to make a difference before it happens, or being able to make a difference for the people it affected. So we have a pretty robust hospital-based violence recovery program. Nationally, they're known as violence intervention programs. And what we do is, it actually starts with our pastoral care. They're the ones there to support the patients and the families when they come in the trauma bay. They're the non-medical person who is there for you, and they're there to get the families, hopefully, the answers they need and connect them to the healthcare providers, and there to support the patients in contacting their families and whoever they need to reach. And then it goes over to our violence recovery team, who are peer mentors who work intensely at the bedside with our patients and meet them where they are. what's your immediate goal while you're here in the hospital? Maybe it's they don't have somewhere safe to go home to. So we work on housing and getting them somewhere else that is safe and secure with the immediate needs. Or maybe there's no food at home. They have been in the hospital a week. They haven't worked because they're here with us. They're injured. Maybe it's helping with bills or utilities, all sorts of things. And then, of course, like the psychological support. In Philadelphia, especially during the pandemic, the wait time for anyone to get mental health support was just astronomical. So, you know, we managed that by adding psychologists just to our team, just to start. They're here available in the hospital to start talking when we see people having the flashbacks and acute stress reactions right here, provide some support with that. And then both our peer mentor team and our psychologist team can follow the patient into the outpatient setting. So they're already familiar with their team. They know their people that they're working with, and, you know, they form a really good bond of, you know, I can call my violence recovery specialist for all of these supports. So really anything, they're going to figure out how to connect them or how to make that thing happen that they need. And then they have that behavioral health provider already lined up and ready to start seeing them in person, virtually, whatever makes sense to them. The one thing that first, I think having this program is just so valuable. It makes such a difference for our patients. We have some like really, really phenomenal stories, like a couple young men who came in, one wasn't even currently going to school at age 16, came in after a gunshot injury, worked with us, and graduated high school on time. Got him through that and on to like some really cool things in our life. And like that's a big shout out to Rodney, who's our lead recovery specialist, because he worked so closely with him to make that happen. And like many, many more stories like that. These are like the little things that, you know, that having your high school diploma, you know, sets you up to move forward in life and go on to do better things in life. And, you know, someday that young man might be the person who's, you know, talking the next young person out of doing whatever it is that they're doing, or helping support them move into a better place. Just the key thing on that for just about all of our hospitals, I'm sure I can speak, these programs are grant funded. We need the legislation. There's precedent out there that Medicaid can cover programs like this. We need to bring that to Pennsylvania too. So depending on what piece really you feel most important about, but that's one that really means a lot to me, is making these programs now sustainable. We have them, we're proving their work, we're proving they do great things in our communities. Now, how do we keep it going? Thank you.
Well said. Thank you so much, Sunny. And yeah, that's actually in addition to, you know, some new laws like Sunny talked about, you know, addressing the threat from ghost guns. One of the really big bright spots we've seen at the policy level, at the state budgetary level over the past couple of years, has been a lot of funding for these kinds of programs, oftentimes community-based programs that sometimes piggyback with hospital-based programs. Over $200 million over the past 3 years at the state and local level has been allocated toward funding these programs. And yes, we are actually, CCRP is involved with trying to open up Medicaid dollars for those reimbursements too. So a lot of really great work being done. Thank you, Sunny, for all that great information. And thank you to all of the panelists for really sharing your expertise there. There's been some great questions already submitted. I want to give you guys a little bit more time to get your questions in. So I'll kick us off with one addressed to all the panelists, and I'll call on you one by one here on this topic of vicarious trauma, because you see a lot of difficult stuff in your work, and I'm sure many of you listening on the call do as well. So to our panelists, how do you cope with this vicarious trauma? How do you avoid taking it home if that's even possible? What can you share with other healthcare professionals listening now who also struggle with dealing with the pain and harm that they encounter daily? And first, I'll ask Jill to chime in.
Thanks. So I think that I do a few things. You know, all the things that we see in the trauma bay are and throughout the course of the patient's stay are they can hit your soul. There are some that are definitely worse than others. I think that I am one of the ways in the real bad traumas is that I try and take care of my team members. You know, if we have a terrible death, I try and help with that aftercare, so that the people that were at the bedside giving the care can step away and take their own time because they have to go back to work and continue to take care of patients for the rest of their shift. So that gives me some relief that I am helping them. And then for me personally, it sounds cliche. I'm a big family person. So, just spending quiet, real time, no phones, just with my family, can fill my cup back up. Getting outside and just breathing some air and getting some sunshine. Hopefully it's a sunny day or something, really does help. I try to do mindfulness and meditation. I am horrendous at it. I'm a little too ADD for it. But it's an ongoing, process that I'm trying to do, but it's really very, very, it's the most important to just so that we can come back to work tomorrow.
Thank you, Jill. Bob.
So yeah, and my comments to follow and earlier represent the viewpoints based on my personal experience accumulated as a trauma surgeon over my 25-year career. So during those 25 years, I've had to tell loved ones bad news too many times to count about an injured or deceased patient. It can be difficult to always compartmentalize it, although we try, I think. And there have been at least a few times in my career that I have brought that emotion and sadness to home. I remember a particularly difficult case that I was actually, my youngest daughter was probably, I don't know, 4 or 5, or maybe even less, probably 3 or 4. And I remember crying, and she asked me why I was crying. And then I just danced with her to our favorite song. So that does help. And I think the biggest thing for me is my faith, belief in God. Though I may not have been able to save the patient, right? I don't save the patient. My viewpoint is always I'm there to do what God wants me to do. And maybe it's not to save the patient. Maybe I'm there to help the loved ones. Maybe, I don't know, something. Maybe there's something I can look at that can give me a different focus. I think my wife is a huge support. She's had a 20+ year career as a trauma nurse and understands what I do. So she's truly a source of strength and compassion. And then lastly, the biggest thing that not at home, not in faith-based necessarily, is taking advantage of counseling. We have an employee assistance program where I work that's just incredible. It's free and confidential. The records aren't mixed with the medical records, so it's truly a confidential service. And I know several colleagues, including myself, have taken advantage of that service. Don't let it stew. Don't let it build up. Don't push it under the rug because you end up tripping over the lump you created. And get help if you need it. It can really eat at you if it's really bothering you, really eat at you and have severe effects if you don't get help. So don't be too proud or too, much believing in your own, ability to compartmentalize that not to get help if you need it.
Thank you, Dr. Baracco. From a personal perspective, that really resonates with me. While I'm not a medical professional, a healthcare professional, as an advocate for gun violence prevention, I talk with survivors all the time, and I always tell our team members, we ourselves are exposed to such difficult stories, and we have to take care of ourselves before we can take care of anybody else. And so I think normalizing that desire, that need to get help and to seek counseling is really important. So thank you. And a great transition to our psychiatrist here. Dr. Darcy, please go ahead.
Well, I see a lot of things in a lot of different spaces because I see a very big variety of people that are struggling, right? And sometimes those don't get better. I try to think about when I'm having a lot of emotions and frustrated with whatever is going on. I try to think about, and this is, sort of a way I compartmentalize, is that I try to think about what is going to be most helpful to the patient. I try to rationalize that like my emotion about it is telling me that I'm distressed because there's something perhaps that I can do to be helpful, or maybe not. Maybe I just need to, kind of come to some acceptance about, you know, making sure I've done everything that I can do. And again, planting those seeds, providing support, recognizing if I do need to step away from something that's pretty sometimes you know, if I'm following somebody for a long time, or, you know, they're having a tough time, or perhaps our relationship isn't going as it should, then I take the time to talk to colleagues about it. And that way we come up with a plan to support that patient, as well as supporting myself. Right. So I think that you know, have a sense when I'm struggling, not all the time, but I think I'd like to check in with myself, when that's occurring. And I really try to meet that patient where they're at, and support them the best that I can. And yeah, sometimes, I mean, family is great. People that really understand what it's like, to work in these kinds of very acute situations, can be quite helpful. You know, hang out with my dog, he's the best. Right. So pets, family can be really helpful. As Bob kind of alluded to, we do also, I would say many places have either peer programs, which are amazing, EAP programs, so employee programs for assistance, that can really go a long way. I think we need to continue to, you know, destigmatize, getting help. Like, you know, this is a lot. We deal with a lot. I think we've seen that in COVID, how much, you know, and even as we continue in a pretty stressful healthcare environment in terms of staffing and resources, you know, how we can support our colleagues and support ourselves, and help our patients. So right, we also have, when a serious event occurs that's causing some acute distress or moral distress in patients and staff, we have another sort of support team that can help. That's called ASAP support at UPMC. So that can be really helpful. So, you know, I try to meter my emotions, see where I'm at, see why I'm reacting in ways that I'm reacting, right? I mean, that's the psychiatrist in me, but also, you know, ask for help when I need it as well.
Thank you, Darcy. And Sunny, you touched on this a little bit in your remarks. Would you like to add anything else?
Sure. Yeah. For me, a big piece of, I came with so much vicarious trauma. By the time I finished my master's degree, I was actually like ready to just give up on nursing, and then was so fortunate to come into this role. So for me, it became like empowering to be able to change the course of what's happening out there coming into this role. But my other advice as someone who's really gone through it with trauma is learning when it's time to take the day off. You deserve that day. Trauma-informed care is so important for our patients, but it is so important for our health systems that I think we could all do a little better right now in how becoming a trauma-informed entity, our administration takes care of us, and understanding like I can always have a sick day. I will call it a sick day. Sorry to my boss who's on the phone. But is it a mental health day? And it might be. And it's fine, right? It's got to be fine. Taking those days that we need when it's just become too much. But before it gets to be that far, using the EAP, like Dr. Bracco mentioned, I think is really important. I think really important debriefing after. You know, I don't ever want to say anything we see in trauma is normal. None of it's normal, right? It shouldn't be happening, but there's always going to be that one case. I think Dr. Bracco even mentioned, you know, a child of similar age to his own. There's going to be those cases that stand out to us more than others. You know, checking in with our teams, what type of support does our team need? Do we need a group thing with EAP or staff support therapists, whatever it is that we have? To really ensure that we're taking care of our providers, because if our providers aren't cared for, that's going to get passed down to our patients. So it is really worth investing in on the health system, and is making sure our providers are really doing it.
Wonderful. Thank you. Well, we have some time, about 10, 12 minutes for questions. We got some really great ones submitted. This first one from Rochelle, I'll just open it up to anybody here on the panel who wants to talk about it. In your experience, what's the correlation between domestic violence and gun violence, and screening for domestic violence in healthcare as a means of gun violence prevention? And I can really quickly speak to that first part. That there is a very clear correlation between domestic violence and gun violence. there's about a 5 times likelihood, a 5 times higher risk of a domestic violence situation becoming fatal if there is a weapon in the home. And so that kind of general stat tracks for all types of gun violence, but it's an especially acute thing for domestic violence. And that's why we at Ceasefire PA advocate for things like an extreme risk protection order, often called a red flag law, which is a way to even more quickly than a PFA, a protection from abuse order, which, if it's finalized, does require relinquishment of the firearm. But an extreme risk protection order, you can, as a loved one, as a law enforcement officer, petition a judge to go through a much more quick process if you can provide compelling evidence that there's a domestic violence threat, to temporarily restrict the abuser's access to firearms. So that's one of the bipartisan bills that has actually passed the state house and is sitting in the state senate right now. So there's that piece. But anybody on our panel here, how do you see the connection between domestic violence and screening for that in the healthcare system? How do you intersect with this issue in your work?
I can speak to, we need to be screening for it all the time. That's something we really kind of try to get residents to speak of, because if we don't ask, they're not going to tell us. So it's so important to just get over it and do it, because you got to do it. Like, and the more you do it, the more, asking about, trauma. Many people go through trauma all throughout their lives. And the more we ask about it and the more we normalize asking about it, I met a 50-year-old woman who disclosed a trauma that she'd never told anyone, and actually I think that it was freeing to her in a way, because, she was like, wow, I've just felt so much shame about never asking, but never being asked. So, I think it's really important to make that part of our evaluations, and normalize that, right? There is a huge correlation. There's, and intimate partner violence happens in a lot of different ways and settings. So it's really important to ask.
Yeah, specifically over 50% of intimate partner violence related homicides are by firearm. Yeah, I mean, it makes it even more important to screen for firearms should the person answer the question. And I've been asked it even in all my office visits, do you feel safe at home? And those types of things. So yeah, the data does seem to indicate that that if you're screening for one, especially if you find a positive screen for intimate partner violence, that begs the question of whether there's a firearm around.
Thank you. Great question here from Susan. What do you tell patients and family who say that locking up guns prevents them from getting to them quickly in the time of a break-in, for example? I've certainly got my answer, but I want to.
I was so I was going to say, the chances of a home break-in while they're there, they are significantly lower than an accidental or intentional use by an owner or someone that lives in the home. A child that is having a bad day and can't have that foresight that things get better, or, a really angry husband in a bit of a volatile relationship. It's much more likely to harm the people in the home than to get the bad guy that you don't know is going to come. That's, that's all I can say about that.
The one other thing I can offer up is meeting your people where they are. So cable locks seem to be a really big problem because it doesn't have that quick access. And everything Jill said, I agree with 100%, but sometimes you can't get past that with some people. So looking for the alternatives, what's the next best? And so that's where we went to move with the gun safes. Is the cable lock is going to take you too long. The gun safe is going to give you that quicker access, so it's ready when you want it. I don't love that, but I love it more than a completely unsecured firearm. So let me meet you where you are with that. And then how do you pull that off? Because gun safes aren't the cheapest thing out there, not as cheap as a lock certainly is. Look for funding, look for grant programming. If you've never written a grant before, I didn't before I did this job, but turns out it's just like writing a college essay where they give you the entire outline, you answer the questions. It's actually not that hard. It's just time consuming. So you write for it, you get the funding, you know, and see what your people need and what you want. So we're going to get out there with these safes now and see if this really does make a difference. That, you know, the cable lock, I understand why you don't like it. What do you think about this? That it's a quick punch, 1, 2, 3, 4. Please don't use that as your code, but something else, and it pops right open. Yeah.
Yeah, I was gonna make that exact point. And there's a question here from Eric, who is a police officer for 21 years now, a paramedic for 15 years, talking about gun safes that can be very affordable, $30. And yeah, these things, you know, technology, you can sometimes have, even these are more expensive, but you can have fingerprint activated ones, you know, even retina activated ones, simple key code activated ones, and you can have that if you need. And as Jill talked about, the idea of a home break-in, it kind of weighs heavily in most people's minds, but it actually happens quite rarely statistically, and the risk of having a gun in your home unsecured is much, much higher than the risk of a home invasion. But in that event, with a lot of these simple gun safes, as Eric talks about, you can have access to that firearm if you need it very, very quickly, while also keeping it out of the hands of kids and other people, preventing theft, which is a huge issue in terms of fueling the illicit gun market. And Eric, to your question, he asked about like what programs have hospitals done or others to help push out these gun safes, not just the cable locks, which are good, but gun safes are even better. I know UPMC over here in Pittsburgh, they have done a number of gun safe giveaway events that Ceasefire PA has participated in, where you kind of come to an event and they oftentimes have them at like a Bass Pro Shop or a place where they sell guns, huntings. They had one at a firing range that I came to, and they will have a series of kind of educational tables. You go around, get your ticket stamped, make sure you went to each table, then you get a free gun safe at the end of the day. So a great way to kind of incorporate education and prevention into a medical context. I did want to, I think we have time for 1 or 2 more questions here. I'm sorry we won't be able to get to everyone's questions. But some of you shared some really great examples of like wins. You know, and on this topic of this can be a difficult line of work. I'd love to hear some of your wins. You know, what are some great conversations you've had where you really kind of saw somebody's mindset shift, or you really feel like there was a really imminent risk here, and something you did, some intervention really helped turn things around. Because I think I really would like to help encourage all the listeners to feel empowered to take some action in their own professional lives. And I think some examples you give could help do that.
Wow. Okay. I mean, yeah, our high school graduations, I think, are some of the biggest wins. You know, trying to find whatever resources it takes to do that. But, you know, going maybe a little into the domestic violence, but not specific domestic violence. We have a lot of people who are afraid to go back to where they came from because the person who hurt them is still out there. And coming up with grant funding and with other community programming that's available in Philadelphia. Our DA's office has programming, and several other organizations around the city have programming specifically to rehouse people who are at risk for gun violence because the person who shot them is still out there. So those are huge wins. We recently supported a patient, although the DA's office paid for his relocation. This individual stuck it out in a hotel for several months until we were able to find him secure, stable housing, affordable to him, supported him through getting back to work. And then, like, what do you need? You're starting off an apartment with nothing. Like, you need bedding, you need towels, you need cleaning supplies. What can we do to, like, you know, get you back on a good spot so you can take it from here? And, you know, like, it was just really great to be able to do that and get him up and going. In years past, we've done things like toiletry drives because it's, like I said, you're going to a new place, you're starting with nothing. So yeah, having some soap and toothpaste is really, really important. And then this year we were fortunate enough that an organization in Philadelphia actually donated us a lot of toiletries. So right now I'm sitting on that, but being able to give that out wherever we need it. So holding those little drives in your hospital. I right now have an ongoing clothing drive because same thing, you're relocating with what you came into the hospital with. And if you've worked in the trauma bay, you know, we've cut all those clothing. So you're going with nothing. So being able to give people some clothing, things they can wear while they're, you know, in transition has been really important. So just all the little things you can do to support it. It doesn't sound like it's not that hard to have a clothing drive or toiletry drive or any of those things, but it is so meaningful on the other side and helps get people to where they need to be.
I would say that at Temple, we have our victim advocates and our trauma case managers and things like that, where they do meet the patients at the bedside, not for counseling. They're lay people. But there is discussion about, you know, a lot of trauma, a lot of gunshot victims will say, like, this is the most horrible thing, and I wouldn't wish that on anybody. And really at that moment, like, we have to try and capture that as this, you know, a turning point in your life. So I'm not saying that you deserve this, but were there choices in your life that you can be changing to help mitigate that risk? Can we talk you down from trying to go after and retaliate? Things like that, that it's really one-on-one conversations, you know, not overlooking people's emotions and their situations and meeting them, you know, as they come, and just trying to work with them at that point. And then hopefully building relationships while they're, you know, recuperating in the hospital, and being able to develop that and you know, tuck them in with some resources on the outside and things like that, so that this is a one and done, hopefully, and there's not sequela from that. That's the most that I would be able to say.
Okay, not hearing anything else. I know we have other questions we're not able to get to. I'm very sorry. We ran out of time here, and I do want to respect this 1 o'clock stop here. But hopefully this is an opportunity to, you know, keep having these conversations. If you'd like to partner with Ceasefire PA on holding a similar event like this for your colleagues, I think it would be a great chance to get more of these questions answered and have more of these conversations. I want to again remind you that April Smith, MPH, is our new public health partnership coordinator, and she will be in touch later next week via email with information about how you can claim your continuing education credits. And I also encourage you to work with April on building more partnerships with your colleagues, as they talked about, to help continue educating and engaging both the healthcare sector and the public in the vital work of firearm injury prevention. I'll drop April's email in the chat right now if you'd like to get in touch with her. Multitasking here. Okay. And, you know, I really hope that you found today's session informative. But as we've already talked about, I hope you found it empowering too. Because as you've seen, the voices of healthcare professionals are so critical to the public conversation around gun violence prevention, and taking a public health approach to addressing this crisis. So if you felt moved by today's conversation and want to get more involved with Ceasefire PA's work to advocate for policy change, primarily we work at the state level, but also federal level, I have an easy way for you just to do that. You can sign up to join Ceasefire PA's This Is Our Lane coalition. We're on the ground floor getting it started. We're building a group of healthcare professionals and public health experts to do things like speak at public events, lobby legislators, write op-eds, and help educate the public to shift the narrative about gun violence. Here is a link in the chat to join, and April can get in touch with you with next steps. You may recall a few years ago when the NRA kind of scolded medical professionals and doctors to, you know, quote, stay in their lane. And the response was overwhelming, that firearm injury prevention is your lane as medical professionals, as public health and healthcare professionals. So if this sounds like something you're interested in, please do sign up. It's not required to get the credits, I promise, but we'd love to have you, and love you to have you stay with us and our new public health coalition for gun violence prevention. So thank you again so much for joining us for a really great discussion. Have a great rest of your day.